What's up, Naki?
What's up, Carl?
Oh, it's another Monday, but we're breaking news this time. We got the data people on, and they're going to break news and give us new information that people don't have. So I'm excited today to be on Koviki Talk, our very own multi-episode series where we talk about all things COVID-19, but from the PI perspective. And so we always give examples of. Actually, we were talking in the pre-show about how we're still on Zoom. We're still doing this virtually, and we didn't
Mhm.
think we would still be here, but here we are. And that's one of the things that we've done well as a community and as a people is adapt to what we need to do for our people. So it was vote in a pandemic, it was register for the census in a pandemic, it was get tested in a pandemic, and now it's about getting the vaccine and getting information, accurate, timely information about the vaccine so that the hesitancy is what we're calling it can be reduced and we can get accurate information. So, who better to get the information from than our own people to talk to us? So, we're going to go ahead and introduce our people. I'm looking forward to our icebreaker question because Naki, you've been knocking it out of the park with these. So, today we have one of our guests with us is Corina Peneaia. She is an MPH, Master's in Public Health, the Community Engagement and Research Director of the Native Hawaiian and Pacific Islander Data Policy Lab at the UCLA Center for Health Policy Research. Peneaia holds a bachelor's degree in biology from Pitzer College and a master's degree in public health from California State University, Fullerton, and will be pursuing a PhD in health policy and management at UCLA. Her experience includes implementing public health programs in underserved communities, in which she has garnered a passion and extensive expertise in producing culturally relevant and sensitive programming around food insecurity, chronic diseases, and related policy and advocacy while working with policymakers and community stakeholders to address prevalent health issues in the community. Welcome, Corina.
Okay. Next, we have Karla Thomas. MPH is co-founder and policy director of the Native Hawaiian and Pacific Islander Data Policy Lab at UCLA Center for Health Policy Research. She also co-leads COVID-19 response work in the Inland Empire with Pacific Islander community-based organizations. She is passionate about advancing health equity for the Pacifica community through data, policy, and activism. Welcome, Karla.
Hi, thanks for having me.
And our next guest, Naki and I were told when we were approached by a media organization to do some shows about COVID 19, we were told that this man was very, very hard to get a hold of. He was hard to book. He was very busy, and we told them that we might have an angle at getting hold of this guy. So Dr. Reyno Samoa is a clinical research endocrinologist. He has a lifelong fascination with obesity related disorders and has parlayed that interest into research projects investigating the metabolic conditions that affect populations vulnerable to diabetes, such as Pacific Islanders and cancer survivors. Dr. Reyno Samoa received his medical degree from the University of Washington. He did his adult endocrinology fellowship at the Los Angeles County University of Southern California and his pediatric endocrinology fellowship at Children's Hospital Los Angeles. Currently, he is an assistant clinical professor at the City of Hope Medical Center in Duarte, California. Dr. Samoa is also the lead for the Healing Associations of Pacific Islanders, HAPI Doctors, which is an organization under the National Association of Pacifica Organizations, NAOPO. Welcome, Dr. Samoa.
Thanks for having me.
Take it away, Naki. I've been waiting to see what the icebreaker question is. You've been killing it the last couple of weeks, so let's get to that.
Man, so much pressure. So the question today is, if you could choose any person from history to be your imaginary friend, who would it be and why?
Ooh. You want to model that question, or are you going to throw it out to somebody in particular?
Let's go with Dr. Samoa. So give the ladies some time.
Because I love her voice and I'm a big fan of poetry. Probably gonna go with Maya Angelou.
Yeah,
Yeah.
that's a good one.
Nice.
Good one. I like that one. How about you, Karla?
Also because I love poets and strong women of color and someone who is now part of Pacifica history, I would choose Haunani K-Tras,
Yes.
Paradise. For obvious reasons, she was a strong Pacifica woman, and in doing this work, I think she would keep me grounded. So yeah, having her by my ear to give me advice would be awesome if that was possible.
That's awesome. That's a good one too. What about you, Corina?
I think I would love to meet my late grandfather, Dr. Lanu Peneaia, who used to do a ton of infectious disease work back in Samoa when he was practicing as a physician, and helping the people of Samoa and across the Pacific. I think it would be wonderful just to learn more about what he's done and how some of that has trickled down to the different treatments and clinical studies we're seeing today.
That's awesome. That's awesome. What about you, Carl?
Ooh, that's a long list. You got to pick one.
Yeah.
I think I would like to know Queen Liliuokalani in the overthrow of the Hawaiian monarchy. She was she learned both cultures, so she was highly educated both in the Hawaiian culture and in Western education. Held she went to meet with the president, and that's a brown woman, um, way before other people were pushing that
Mm.
envelope and demanding sovereignty and representing her people. She had an audience with the president in Congress, and it's something that I think that is not known enough in our history of the things that she did. So it would be the queen.
Yeah, that's awesome. Ah, geez. I was going to say my grandmother, only because she was a nurse way back in Samoa early where, and she used to leave her kids, her and her sister were nurses, one of the two nurses in Samoa, first nurses in Samoa. And they would leave their kids with their older brother. So my mom is really close with her first cousins because my grandmother and her sister would go to other islands and people would actually call for them to go and mend what their spouses or their husbands or their kids. And we have land in Tafuna, and the reason why we have it is there was a high chief. His wife was very ill, and they didn't have any kind of what is it, Western medicine. So my grandmother went and stayed with them and literally nursed her back to health. And so he had property in Tafuna and gave it like all this land to my grandmother and said, because when you get off the plane in Samoa, you have to go through Tafuna to get to the rest of the island. And they said that, he said, I give you this land so that when people come from Samoa, when they go through Tafuna, they'll be touched by an angel. And so that's been our family story forever. So I've always wanted to really meet her and probably follow her around and see what were you doing and the sacrifices that they left their husbands and their kids to go to other islands and take care of our community. So, and that's what we do. It's just, so I would really like to have met her because I didn't spend a lot of time with her. So yeah, those are great people that we want to spend time with. And thank you.
Great question. Great question. So this is really one of those. This is an episode where a lot of times we have a good idea about questions we want to ask or topics we want to bring up, and really all I could come up with as we came into this show was that data is king, and we are finally getting our own data. So in order to steer our ship and be a pilot or a captain of our own ship, we got to have our own data. So with that, I'm going to turn it over to Dr. Samoa or Corina or Karla. And that's one of those things in a PI show when you say, I'll go ahead and open it up. Everybody's humble and there's like a big, long, silent space. But I'm going to do that anyway because I don't really know where this is going to go. I just know that I'm excited to have us getting our own data and having Pacific Islanders share that data specifically to our audience. So I guess I will turn that over either to the ladies or Dr. Samoa.
So I'll provide some framework for us. I too, Carl, used to not know where we were going. I just was excited to get in the car. I think we'll go over some of the data we got from the survey regarding the most riveting data was the data that we got surrounding the vaccine, the hesitancy around the vaccine. But I think probably before we go there, we need to sort of understand why is it important. Yeah. And so if Corina and Karla, if you guys could update us on sort of like our status, mainly in California, because this is a California focused episode. Do you guys mind sort of going through like how we're looking in the different counties?
Sure. So in terms of the status of COVID in the community, with COVID, there are 17,130 NHPI COVID cases, and there have been 343 deaths total in California. And using those rates that are as of the beginning of this month, August, NHPI still are trending as having the highest COVID-19 case and death rates out of all racial and ethnic groups. And of course, there's the vaccine that's been going on, and you mentioned that there's hesitancy among the community, and of course, data that we want to share. But I think that we need to also preface the data before going into it. So I'll pass that to Corina.
Definitely. Thank you, Karla. As she mentioned that there are definitely some details that we want to cover before we dive directly into some of the numbers that are reported at a state level, but just amongst the United States. So we know that there are a little over half of us in the US population who have been fully vaccinated, whether that's Moderna, it's the J&J vaccine, or it's Pfizer. And just a little update that the Pfizer vaccine has been fully approved by the FDA. Before it was only approved for emergency use authorization for those who are 12 and up. And now it has been fully approved for those who are 16 and up. So just wanted to share that update as well. And the other vaccine providers are working to submit those applications to ensure that we are able to fully approve that. So that will hopefully encourage those who have been a little hesitant or they're taking their time to decide whether that's the right thing to do. So hopefully that will encourage folks to take that leap of faith once they're ready. So within California, right now, if you were to go onto the dashboard and look at some of the numbers, you would see that it lists 109.2% NHPIs are vaccinated, and that is well over the 100% threshold. And there are several issues as to why this may be. We are seeing self-reporting issues. This comes down to how people identify. There have been several issues where folks who do not fall within the NHPI category accidentally self-report themselves as that. And we do know when we are scheduling appointments for our community members, it is up to us to make sure we are self-identifying properly. So that can be one issue for such an overinflated number that we're not only seeing at the state level, but also at the county level. And we'll talk a little bit more about that later. Some other issues for inaccurate counts may be the census. We talked about this a year ago and how important it is to ensure that we are counting every single cousin, auntie, brother, sister, you name it. And when we don't have accurate numbers, we get overinflated counts, as mentioned before. And one thing that's continued over decades is lumping Asians and Pacific Islanders together. A lot of these local health county departments, they continue to put our groups together, which masks those unique differences that we have. which limits some of the resources that we do have to pass out to those who really need it. So those are some of the specifics as to why we're seeing overinflated numbers. If we wanted to dive down a little deeper into some of the counties who have been sending out some of their reports, definitely want to acknowledge the PI task force in the Bay Area. They've been working very closely with a lot of their community based organizations, the different faith-based groups. So for example, in San Mateo County, those who are 12 and up, we see about 1.44% of the NHPI population vaccinated, so that's both doses. And then for those 18 and up, we see 59%, which seems pretty reasonable considering all of the outreach efforts that have continued on. If we wanted to hop down to the SoCal area, such as San Bernardino, for those ages 12 and up, we do see about 50% NHPIs in the San Bernardino area who are continuing to get vaccinated and hopefully share that information with their families. So those are some brief overviews of the numbers that we are seeing. And if people do have questions about specific areas, feel free to ask at any time.
I had a question about the census. So is there any opportunity, I mean, the next census is years away, right? But this, because it's so close to the census, when the census was taken, is there any opportunity to gather data where we have overinflated numbers that we believe would be a result of underreported census numbers? So if we had a county like San Mateo County, just take that for example, if we ended up with inflated numbers of COVID related numbers, that would leverage us to be able to say, look, we need to get a better count every year. But specifically because COVID is telling us on the peninsula, we really didn't do a good job of getting people registered for the census. Is that even a thing? Because I'm just thinking of that as you're talking about inflated numbers. Would that be a data that we would want to keep for heading into the next, thinking ahead towards the next census?
To my knowledge, at least for the past census that we were collecting numbers for, there was definitely a push to extend the data or the data collection. So we did have a couple months after that, but to my knowledge, once the collection is closed, we are working with those numbers and those numbers only. However, there may be times where maybe we can input that these numbers don't look accurate, but I don't know if that's actually reflected or changed over time. But maybe Dr. Samoa, I don't know if you're aware of how the census continues to collect data.
I'm probably the wrong one to ask, like census data is particular, and there's efforts to try to get an accurate count, but it all boils down to we didn't do great. We didn't do great in 2020 in regards to collecting census data. And a lot of it sort of comes from not using our wisdom regarding community engagement to its fullest. And so there's a lot of room to improve. And the survey that we're going to go over gives some examples of how we could do that. Yeah. So maybe that's a good segue. Yeah. So the Tri-Caucus had put forth a request to gather data regarding communities of color during COVID, because there's a lot to be said about sort of the disproportionate impact regarding communities of color. And there's not a lot of data, in regards to how these mitigating factors, how bad they are, where they're bad. And so Congress put forth this call to get that data. And so let me see. Is there a way I could share a screen? It says the screen sharing is disabled. Any possibility?
You should be able to share.
Oh,
now.
they just let me. Okay, give me 1 sec. Yeah. Can you see the screen?
Yep.
Yes.
Okay. So real quick, like we said, this is the band of researchers that came together, and Niai Toto and myself spearheaded the Native Hawaiian and Pacific Islander aspect of the needs assessment. There is no going forward and collecting meaningful data in our communities currently without community effort. You know, COVID is one of those rare examples that they're gathering data, you know, without a huge part from the community, but the reporting of that data has largely been influenced and pushed by the community. And as you can see, because this was a national project, we needed to work with community-based organizations to gather respondents. Now, here's the thing about community efforts. If you don't have a role, if you don't have an established relationship with community, you're not going to get one because we have an incentive, right? And so a lot of the rich data that we received came from the established relationships all of our partners had with the community. And as you can see, it's a pretty extensive group because it was a national effort. So we were able to field about 1,200, a little over 1,200 respondents across the nation. And our geographic distribution fit the census, right? So the predominance of our respondents were from California, Hawaii, Washington, Utah, Arkansas, Oregon. And our breakdown was predominantly Samoan, but it was a good distribution. The only difference between the sort of our census population and our population was the Native Hawaiian group. That's because Native Hawaiians in Hawaii were left to the Indigenous Wellness Research Center to survey, because that's what our Native Hawaiian partners wanted to do. So we left that to that group in the University of Washington to gather. And so the biggest thing from the national data has been the vaccine hesitancy. So as Corina reported that about 50% of the population currently is getting vaccinated, that fits with our data, that about 46% of Native Hawaiian Pacific Islanders were hesitant to get the vaccine. And then when we break it down by state, as you can see, there's a lot of variability when you go from state to state, where on the West Coast, you see less hesitancy. So the numbers down below basically tell you the percentage of the NHPI respondents from that area that were hesitant to the vaccine. So on the West Coast, where you had Washington and Oregon at vaccine hesitancy rates of around 25%, that kind of matches their vaccine data. They're reporting in King County and Multnomah County, which is where the predominance of Pacific Islanders live. Their vaccine rate is about greater than 75%. So that matches. And then in Hawaii, it's about 30%, and then in California, 39%. So the most striking is the vaccine hesitancy in Arkansas and Utah. It's 71% in Arkansas, and it's 64% in Utah. The Utah respondents were predominantly Tongan, because it was the National Tongan American Society that was our community partner. So a lot of this reflects sort of the Tongan sentiment around vaccines in Utah. And in Arkansas, because the ACOM is our partner there, the predominant respondents there were Marshallese. And so this kind of fits with what they're reporting as far as vaccination rates. Their rates are somewhat low. And so you can see it matches. So our data kind of fits with with most of the states, except for California, as Corina already reported. And so we'll talk a little bit more about sort of the nuance of California. Um, and then one of the other things that we noticed was there's some hesitancy that are based on differences in hesitancy based on your educational attainment, right? So people who have graduate degrees and bachelor's degrees seem to have a lower, they're more receptive to getting the vaccine. And then as you go, as when the high school and associate degrees, they tend to have higher hesitancy. Same thing with the income. Uh, those who reported to make 100,000 or more tend to have less hesitancy, and those with lower reported incomes tend to have higher hesitancy. And so um, some things that didn't have to do with the vaccine that we got from the survey was that there was sort of a spattering of difficulty seeing a healthcare provider before the pandemic. It didn't seem to have any rhyme or reason as to why people had trouble seeing their healthcare provider. But after the pandemic started, across the board, people were reporting high rates of difficulty seeing their healthcare provider. And the number one cited reason was the change to telemedicine. So that's unfortunate for us because almost every talk I've gone to regarding doctors, telemedicine seems to be a strong part of the medical community's approach. And as you can see, we're struggling with it. And then there was a high rates of depression and anxiety reported in a lot of the different ethnic groups. This is the other reason why the data is so rich, because there's some big variabilities regarding the different ethnic groups and their mental health needs. And so I'm going to stop there for now before we get into the California data.
Dr. Samoa, do
Yeah.
you have any thoughts on um, the fact that we're more likely to hold jobs that are essential, that are deemed essential worker jobs? Yet, and then that would fall, be correlative to the income disparity with the hesitancy. So it almost seems backwards, right? Like we're more likely to be at risk because of the jobs we're more likely to hold, yet we hold a higher vaccine hesitancy, even though we hold those jobs. And I know it may not be data driven, but do you have any thoughts on like why that would be with Pacific Islanders?
Well, I'd love to get Corina and Karla's thoughts before I answer. Do you guys have any thoughts in regards to that in California?
I think it really depends on the circles you grow up with, where you're living, who your families are connected to, because nowadays we know it's not just what you know, but it's who you know.
Yeah.
And it's so difficult now, especially with the pandemic, to secure a job and secure housing. So having someone who is trusted that you can lean on to help you get an extra foot in the door may be a reason why so many of our families are in these frontline essential worker positions. But those are just some of my thoughts.
Karla?
So you're asking about essential jobs and how we're so overrepresented in that area, and then also have more likely to be low income, and then therefore are more vaccine hesitant. I mean,
Yeah, well, so my question would be is because we're more likely to hold those positions, and we're more likely to be in that strata with the income. It seems like because we're at higher risk, we would have less hesitancy because we know we're in those groups, right? We're working retail, or we're working I don't know, construction, or we're in those jobs that are dangerous because you have to work. It would seem like we'd be more likely to be less hesitant, but it shows that that's not the case with the income and the age groups. So I was just curious if we had any thoughts on that.
I mean, my thought is a lot of essential jobs are, or not a lot, I'm sorry. Some of them are, they fall under the minimum wage, and people who can get those jobs often have less options for employment. And then that's related to education. And then I think when Dr. Sawa highlighted that in the presentation, that's like a really big factor of, what influences your health behaviors and what can make that your behaviors more poor and more likely to be hesitant. So I'm seeing, I don't know, I think it kind of makes sense to me in my head about, why they're both in those industries in the first place, and then why they're vaccine hesitant.
Yeah, I agree with Karla and Corina. But I think one of the things that you're just not going to get around is the income and education issue, right? And all you need is one. All you need is one in your family. Like Corina comes from a medical background. Like her dad's in medicine. Karla, I don't know Karla's background, but even myself, like, my mom was a social worker, but there were people getting graduate degrees in my family already. It takes one to open the door, for everybody to walk through. That doesn't mean everybody's going to walk through. Trust me, there are people really resistant in my family, but it just takes one. The other thing about it too is where you hear the noise from, right? Because I'm an essential worker, but what's surrounding me is all these messages around, you know, uh, positive choices, whereas if you're talking about low income essential worker, there's a different culture, there's a different messages feeding into that group. I didn't want to say it, but if you notice, there's a little bit of a political divide between those states that had high vaccine hesitancy and those that had low vaccine hesitancy. I'm not saying that there's anything wrong with that, political disagreement. But it does sort of call to me that there are people in my community that they're not going to listen to me, right? They have a different news feed, they have a different filter, and I think part of what we're seeing is we need to get that group, the Republican leaders in those states, to start jumping on board with the messaging, because one of the things that's very clear is NHPIs, they support agricultural industries. They support a lot of they're in those places because they're supporting that industry. So if that workforce is compromised because of COVID or whatever health condition you want, it only serves to hurt your state. And so, it makes all the sense to me that they join in the message of getting the vaccine. Shall we move into the California data?
Yes.
Okay, let's do it. Oh, let me see. And I do have to say, Corina and probably Karla, because a lot of our respondents came from the Inland Empire, was very instrumental in getting a lot of the respondents from California, especially Southern California. Okay, let's see. California. So the breakdowns in California were slightly different from the national data. There was a little bit of a higher income reported in California, but as expensive as California is, well, what's really not in this is the cost of living. So, if you make 70,000 in California, it's way different than making 70,000 in like Arkansas or Utah, right? And 70,000 in Hawaii, what is that? Buy you lunch or something?
Right. Right.
The essential worker, there was predominance of non-essential workers. I think a lot of that had to do with sort of the generational respondents. And then our educational attainment was a little bit different from the national data. There was a lot more that responded they had some college. But even in California, there was a low percentage of respondents that had graduate degrees. And you know, the bachelor's attainment was lower than most communities in regards to the ratio. So this is the breakdown of the vaccine hesitancy by zip code. And this is the map of the counties, just so you can like reference which counties we're talking about. And then the vaccine hesitancy goes from green being less hesitant to red being very hesitant, right? And so you can see some of the pop-ups to us have been San Bernardino County, where the vaccine hesitancy was the highest out of all the counties at 63%. And then, so I don't know the northern counties very well, but what was flagged was San Mateo County. And so I'd be really interested to hear what's different about San Mateo. And then Karla's our resident expert of all things Inland Empire. And so maybe she can shed light on sort of what we're seeing there. And then there was less hesitancy in Los Angeles County. Surprisingly, Orange County, I don't know, maybe because the sample is really small, the vaccine hesitancy rate is small too. But you know, I look forward to hearing your thoughts on it. And then, so here's kind of where the rubber hits the road, yeah? So when we look in California, vaccine hesitancy by education, it is whoppingly different, right? You have 33% that are hesitant with, you know, with graduate degrees, and 89% when in high school, just high school graduates that are hesitant to the vaccine. 89% is
Hi.
really high.
Crazy.
And then vaccine hesitancy by income, it's less drastic, but it's still very, you know, clear, where the more you make, the less hesitant you're going to become to the vaccine. And then, so this is kind of the socioeconomic status. So income and education attainment are ways we describe our socioeconomic status. And it seems like the higher your socioeconomic status, you know, the better your health is going to be. And the vaccine hesitancy is just sort of one example of that. But you can swap in, you know, vaccine hesitancy with diabetes. You can swap in with breast cancer. You can swap it in with a lot of chronic diseases. And I would bet money that the socioeconomic status gradient holds up. So here's where we have the problem. So there are people like me and other researchers that are in this sort of conglomerate of things that need to move for things to get better regarding the pandemic. So, you know, COVID-19, the problem we had early on was we were only looking at COVID-19 as a biological disease, you know, and if that was the case, the vaccine would have been way more effective. We would probably be done with it if all we had to deal with was biology. It's not. For all those things that I just told you about, education, income, and there's probably a whole bunch of other things that have influences people's decision, you know, like education is up here, financial well-being, that's over here. That has nothing to do with us, right? And so we need to figure out a better model that sort of incorporates all of that and coordinates all of that. And the only way I can see that going forward is through the shoulders of our community-based organizations. And so hence why the PRCRT is sunset, you know, we're sunsetting. So we are transitioning to the National Association of Pacific Islander Associations, or NAOPO, which I'm 100% happy that I'm not the lead. And basically, this is some of the what you were referring to, Joseph, about essential workers. So these are the not hesitants. And this is sort of a breakdown that we can talk about later. So that's basically the breakdown of California. I'm completely interested in trying to figure out what's going on in San Mateo and San Bernardino. Why don't we start with Karla?
Yeah, thanks for asking. Well, like you mentioned, vaccine data or any data for NHPIs is really scarce. And I want to mention that the lab, thanks to a really great volunteer, Jessica Lee, who conducted a data audit on all the health jurisdictions that report NHPI data, and only 17 out of 61 give any information on NHPI vaccine data. And in a lot of those cases, they're very flawed. So it's hard to match or give a, I mean, we can give a narrative of what our CBOs are seeing in their groundwork, but it's hard to match that to numbers that, our local health jurisdictions should be reporting. But for San Bernardino County, like you said, the vaccine hesitancy among NHPIs is very high. And that's, I can say that that's accurate to what we are seeing in hosting COVID vaccine sites with our counties and other health partners like Kaiser and folks like that. It's just very, in general, hard to get the community out there. People are just fearful about the side effects and what might happen if they have a chronic condition already, and if they get the vaccine. There's also just a lot of misinformation being put out there that people believe as truth with the capital T. And when there is a huge education disparity, it's hard to delineate reliable sources of information from unreliable and untrustful ones. So that's what I can say I'm seeing here in this area. And from our leaders, they've been constantly attending funerals, unfortunately, in San Bernardino County, from entire churches being affected, and so forth. So that's what I'm seeing here. And I feel like that's pretty relatable to other counties.
Thanks. I mean, it is unbelievable the level of capacity that's on this call right now. It is amazing that you get to hear all these different layers of the NHPI experience, and with the cutting edge of data, like I don't know. I don't know. I just want to go home now because this is pretty amazing. But before we go further, and I want to get like Naki and Carl's thoughts on San Mateo,
Yeah.
I do want to pay homage to a lot of the community groups that were also very, responsible for getting these respondents. And then I see Tana's blowing up our chat. Tana
Yeah.
was also one of those people helping with the respondents. And so thank you so much, brother, for doing that. But Corina and Karla, did you want to mention any groups that were pivotal in helping us gather like respondents?
Definitely. And then Carla, feel free to add in if I do miss out on anyone. And this is a short list of many who have contributed to not only the survey, but COVID related efforts. We've been talking about this for over a year now, so it's great to see that more folks are jumping in to help with the cause. This may be your volunteer job outside of your regular job, outside of caregiving and, taking family to church and things like that. So definitely want to acknowledge those in the LA County area. As Dr. Samoa said, there is a little bit lower of vaccine hesitancy in the LA County area where we do know a lot of our folks reside. And this may be because of wonderful community-based organizations like Empowering Pacific Islander Communities, under the direction of Tabai Samuelu and Maylin Thompson and her community health worker team, who continue to put on left and right vaccine sites at the Dominguez Samoan Congregational Christian Church in Compton. So I just want to say thank you to them for always opening their doors, not only to NHPI folks, but also the nearby neighbors. And then we have API Forward Movement under the direction of Heng Wang Fung, which we spoke about a little bit earlier regarding the community health worker team they put together last year to focus on generating in-language materials for our Samoan, Tongan, Marshallese, you name it communities, because we know if we don't have those materials in our language, in plain language, it's really tough to go out and spread awareness about COVID-19. And they continue to do food distributions with our NHBI communities. Want to acknowledge Mela Fiba and Joseph Alai, who conduct testing and vaccine sites in the Inglewood, Lenox area, and they're hosting a ton of events. I think they had one today, and they'll have other vaccine events in the future. And of course, we want to acknowledge Tana Lepula, who has put on such a great amount of vaccine events and COVID-related efforts in the San Diego area, doing great work with Kenny and Mona Al Young with the Scripps Health Center. And we just want to thank some of those folks, along with a ton of people in the Inland Empire Pacific Islander COVID response team, like Lolofi Solkai, who has done tremendous work with the Malo CBO. And the list goes on. There are just so many people we want to thank with so little time, but we really do appreciate everyone who has helped us get the survey out, helped us with other surveys, food distributions, PPE, families from out of state calling, asking for wraparound services. We really appreciate everyone.
Thanks, Corina. Yeah, it's what I love about Koviki Talk. You get to highlight some of the hard work, a lot of it uncompensated, that's happening in our community. So I mean, if anything, shining a bright light on that helps sort of give us hope for the future. So Naki and Carl, tell me about San Mateo County.
So San Mateo County is one of the it's like a, how would I liken it to? I would liken it to Orange County in Southern California. It has, so you have the richest, most expensive city in the United States in Atherton. Hillsboro, same thing. So
Yeah.
you've got incredible wealth there. And then right in the middle of it, you've got East Palo Alto. I mean, and you've got stark poverty, and so it's, I don't know, I couldn't really, when we were looking at the map, I was kind of looking at that like, I mean, there's extreme wealth there, and I think it can be some of the disparities, right? The big gap, the delta between the haves and the have-nots, because EPA is as bad as, that's as rough as it gets in the Bay Area. It's every bit as rough as Sunnydale or some areas in Oakland and those kind of things. But I think that there's, that the issues of, like you said, it only takes one. I think there's, the attainment, the education attainment. I think that if you broke it down on the peninsula, San Mateo County, we'd find a lot of those layers that you had in your slides. We would find a lot of that in San Mateo, even though it's such a rich county overall. Like the median is huge, but there's big pieces of poverty as well. Naki knows it well, so I'll let her talk about it.
Yeah.
Grew up in San Mateo County.
I did grow up in San Mateo County, and it's there is the really high expensive areas where there's like we said, there's less hesitancy in that area, but where all the PIs are is in the lower income housing area. And so and it really, like Karla and Corina said, it's who like if you're I don't want to go into religion, but I know a lot of people that just choose not to because they're taking their faith to the full extent, you know what I mean? And a lot of it is education, a lot of if you don't have access, like we talked about this last week, I have access to Karla and Corina and Dr. Samoa, you know what I mean? So I get the information, the right information. If you don't have access to these wonderful people, you're getting your information from Facebook, and just Facebook and your friends said, don't get it. You know what I mean? It's a lot of bad information, and it's because we don't know. I think because at the beginning of the pandemic, nobody wanted to get tested for COVID, right? They didn't know. And you guys were literally knocking on people's doors. Hey, go get tested, go get tested. And then our community started dying. And as soon as they start seeing that, they were running to go get tested. And our numbers now are pretty good at getting tested. But it took a whole year, you know what I mean, for our community to get in there and start promoting, you know, go get tested, because we've been to one too many funerals. And I think where the areas that are hesitant, I believe we have to go knock on those doors, you know, and talk to our pastors again and the CBOs and get back in there and go to events. You know what I mean? There was Aloha Festival in San Mateo, and they had a vaccine, you know, people there giving away the vaccine, you know, you could get vaccinated there. And the team there, Keikoa and Pitt, they were literally walking around and picking the PIs and saying, hey, come here, did you know? And they had to explain why you should and you know, it's just one-on-one. It looks like I feel like we started all over again with the COVID, explaining COVID to our community. Now we've got to explain the vaccine and really get in there and explain to them that we need this. And not that I'm going on a tangent or anything, but, you know, I have a PI friend who's like, well, the CDC said, and I said, the CDC is not talking to our community. They're not looking at our numbers. You know, you're not watching Koviki talk, first of all. You're not following Karla and Corina and, you know, all of the positive COVID groups that have come, PI COVID groups that have come out of the pandemic. I'm like, you've got to follow the numbers that are talking to us. Those numbers, they're not talking to us. So I think that, not that we're at the beginning, but we're slowly starting to touch people one by one. And if not with, like, you know, the groups in LA that Corina had mentioned, a lot of North California, everywhere, you know, OPIC and ACOM, we're like slowly knocking on the community's doors saying, this is why, this is the reason, because, you know, we're getting bad information everywhere. But, you know, a lot of people they see it on Facebook and they're like, yep, that's right. But they really should be talking to, you know, our health professionals and CBOs and doctors like yourselves and Karla and Corina.
Oh,
That's
yeah.
the danger, right? That's the danger.
It's dangerous.
If you don't get your information from a reputable source, you're going to get it from memes and GIFs in the comment section. That's
Right.
where you're going to get your, you know, well,
Yeah.
I read it, you know, then that's the worst. That can be the worst thing, you know, when you're getting your information from the comment section. It's probably not going to be that the quality level is not going to be that high. So I appreciate y'all coming on today.
There's a lot of emails going around about the vaccine causing deaths. But let me clarify that. You know, it's about 200 million cases of COVID around the world and about 4 million deaths.
Mm.
So, you know, that's what, 3%? And about almost 1 billion people have gotten the vaccine, and 4 globally, you know, have led to deaths, you know, and none of them in the US, right? And so when you're talking about equating risk, you're not even in the same ballpark. You know what I mean? Like, you're not even close. And, you know, I've never want to shame one for someone making the best decision they think they can, based on their beliefs. I do have problem when somebody tries to influence someone else, you know. And so, you know, I literally, my mom sent me a message and you know, this email link where people are telling me that the virus, you know, the vaccine is an RNA virus, or sorry, RNA vaccine, and DNA makes antibodies, and somehow the vaccine, you know, causes irreparable damage to your DNA. And I'm like, okay, I don't know, I can't really explain immunology to you. You should make note that DNA doesn't make antibodies. I feel like Pakia Young is like, just felt a chill up his spine anytime somebody says that. And it's all right if you don't know the science.
Right.
It's 100% okay. What's not okay is you pushing things to other people, calling it science. Yeah, because if I'm wrong, you know, it's a big thing, right? It's litigation. It's you know, you have to justify why you're wrong to people. You know, but when people spread misinformation and it leads to death, are they going to talk to the family? You know, are they going to apologize? No, you're not. You're not going to, you know, and so if you're not going to take that responsibility, stop spreading misinformation, right? Because it comes down to the reason why you're giving that information is because you're holding to our cultural value of showing up for one another. I get that, right? But if you want to show up for each other, do it appropriately. You know, don't be telling people how to do taxes if you don't know anything about the tax code, right? Don't go fix somebody's car if you've never touched the engine before. You know, same thing. It's about, you know, responsible capacity. And I don't know, we kind of have to figure out how to infiltrate these areas, you know, but going forward, we're going to have to figure out how to improve that health social economic gradient that we talked about. Because until we do, we're just going to be continuously, you know, vulnerable to any type of public health threat. And as you can see, our numbers from COVID, our numbers in other conditions look just as bad. It's just nobody cared before. Sorry, I just rambled.
No, you're
Take it
fine.
away. Take it away,
No, that
host.
needs to be said. That
Mhm.
needed to be said.
So what are we going to do, Corina or Karla? How are we going to bring the hesitancy number down and vaccine up? Or what is the solution? Or is there one?
I mean, I think that there's no one size fits all to get the community on board. I think that there has to be multiple avenues to target people's decisions in health. And I think that requires to look at public health for sure, because you know, that's part of our expertise, is looking at and examining people's health behaviors and how they make decisions, and putting out the best information out there for people in a way that they can understand and trust and get from a person, you know, that they would you know, just have be just more trust in. And of course, continue to support people who are already doing vaccine work, like the CEOs that we mentioned, and others, of course. And you know, reaching out to our diverse community leaders, whether that's in our churches or in schools or in the employment workforce and things like that. Whoever they may be, it's good to talk to them and help that information trickle down.
Awesome. Thank you. Corina?
Definitely want to elevate everything that Karla has shared, but I really believe it all starts at home. You know, depends on the family values and how you were raised, and if you do go to church, the type of church that you go to and the friends you're around. One thing that's been really helpful for us in terms of outreach, whether it's COVID testing or PPE, you name it, anytime we try to get our information out, it all starts at the church or our cultural groups, where we know our families can gather and feel safe enough to ask questions when they don't know the answer to something, because it's scary right now with all of the different county updates, the different changes that happen on a day-to-day basis sometimes. So being able to go to our trusted messengers has been really effective for some of the projects we've been pushing forward, whether it's collecting data. We're trying to disseminate resources to families who really need it. So I think just leaning on one another, asking questions when you're uncertain about things, and just continuing to work together. I think one thing I shared last time before we wrapped up is just learning how to be kind. Again, that's one thing that goes such a long way.
Yes.
And making sure we're being as mindful as possible, because it's not a very difficult thing to do when you're being selfless and thinking of others. So just wanted to bring that up again, since we're all going through such difficult times personally and professionally. So just trying to be there more willingly for others will help us with these crazy challenges, but we'll get there.
Well put.
Yeah.
Well put.
Well, Karina, that's so true.
I mean, if I could add, like, I think Karla hit it on the head, that one size doesn't fit all. But what we have now is data, right? I mean, you just can't throw money everywhere, expect things to get better. We have identified needs now. We know we have high vaccine hesitancy in San Bernardino and San Mateo. And money should be allotted to those areas to improve vaccine hesitancy. The other thing that we have to be very mindful of, in those places where vaccination rates are high, the mortality rate's still high, right? And so we have to be very clear that the vaccine is not the end all answer for us. And we need more information to figure out, how do we turn that back? Is the vaccine giving us a false sense of security so that we're just letting everything go? And that's why the rates haven't come down. Or is it that, we're dealing with travelers, whatever it is, we need more data around it. And our survey kind of shows that you will not get meaningful data without community effort.
That's right. That's 100% accurate. Awesome. Great information. Thank you so much. We are going to give it a wrap. Did we miss covering anything? Karla, Corina, Dr. Samoa?
I'd just like to say before Naki takes us home, to be on a show where it's been created for the Pacific Islander audience and for the Pacific Islander community, and to have all PIs on here speaking to the community, going over data that we went to go get, that we had to go get ourselves. And we had to, have people like Corina and Karla, and all the people that put these things together. That's it. It just feels so good to, the thing that we say, Naki and always say is, the only one that's going to save us is us. And when I see these things going on, and I see that the effectiveness of the CBOs and the trust that the community has in the CBOs and our leaders gives us these kind of things when we go get the data. It's just, this is a really good show. And this is one of the ones that Naki and I were really looking forward to, from that standpoint of, like, we went to go get our own stuff so that we would know, where and what we need to do. So thank you all. Go ahead, Naki.
Yeah, thank you so much. The work that we had the girls on last year, and here we are a year later, and we're still doing the show because it's needed, and the girls are still busting their behinds to save our community. Also, Dr. Samoa, thank you so much for your time. Thank you for the work that you continue to do to save our community. Me, I'm always crying by the end of the show. So thank you so much for the work that you're doing. Just thank you. I'm at a loss of words. You guys are freaking amazing. Thank you for taking the time. Thank you for the data, for all the research that you all have been doing. And thank you again and again and again for all the work that you're doing. We're here every Monday at 5 p.m. Come check us out. You can play this again if you've missed any part of the interview with Karla, Corina, and Dr. Samoa. We'll see you next week. Thank you.
Oh yeah, don't forget this is a series. So This was the California rollout.
Yes. Next week, we'll have, I believe, Washington State is up next. So yeah, thank you so much, Dr. Samoa, for the reminder. We will see you all next week. Thank you.
Bye. Take care.